Welcome back. So we're going to focus on chapter 10 this week, which will be on mental health, clinical assessment, and psychopathology in older adults. So we first have to understand the relationship between mental health and psychopathology. And by defining mental health and psychopathology, we are trying to distinguish between what normal mental health looks like versus what non-normal mental health looks like. And so this distinction has been historically challenging to define clearly the two. And many scholars either sidestep this question altogether or they try to understand and describe what mental health or psychopathology is not, rather than what precisely it is. And one reason is that it's difficult to draw a distinct line between what we consider normal or normative and non-normal. And behavioral expectations and standards shift significantly across different time periods, situations, cultures, and age. So Buran and Renner offer a classic perspective that suggests that mentally healthy individuals typically share certain traits. One is they share positive self-regard. Another one is they have a realistic perception of reality. The third is they are able to master and adapt to their environment. Another one is autonomy, so they're able to maintain independence. They're also able to have a balance of personality traits and a commitment to personal growth and self-actualization. Assessing mental health status involves evaluating each of these characteristics in an individual. This framework can raise some issues, particularly when applied cross-culturally. Much of the theory and practice in the mental health field stems from Western cultural traditions, including ideas like the separation of body and mind, reductionism, and these have heavily influenced mainstream mental health systems. And while these Western conceptualizations have provided valuable insights and treatment frameworks, they can also create problems when they are applied in non-Western contexts. And so without carefully considering the cultural complexities involved, applying a Western-focused approach to mental health risks are overlooking the unique perspectives and experiences of individuals from diverse cultural backgrounds. The multidimensional lifespan approach to understanding psychopathology considers four main factors: biological, psychological, sociocultural, and life cycle forces. Biological forces include brain changes, chronic illnesses, and genetic factors which can affect our behavior. So for example, brain structure and function impact our behavior, and many health problems like our memory decline and some forms of dementia, and these become more common with age. Physical issues might even appear as psychological ones. So for instance, irritability could stem from thyroid issues, and memory loss might be due to vitamin deficiencies. And so checking physical health and genetics is a priority in a diagnosis. There's also psychological forces, which are the changes in memory, intelligence, social understanding, and personality that happen with age. And this can be tricky to identify mental health issues in older adults. So for example, normal age-related change might look like certain mental health disorders. A person's relationships, especially with family and friends, also shape how mental health symptoms appear. Sociocultural forces are the social norms and cultural values that strongly influence what we see as normal or abnormal behavior. Cultural differences mean that behavior seen as normal in one culture might be concerning in another. It's important to consider if someone's behavior fits within their specific cultural and social context. Life cycle factors are a person's past experiences and the issues they faced over their life, and this can affect their behavior at any age. How certain symptoms are viewed can depend on age. So, for example, waking up very early might suggest depression in a young adult, but could simply be a common part of aging in an older adult. And so these forces together help us understand and evaluate mental health across the lifespan. It's also important to note that social disparities can result in different prevalence of mental health disorders due to inadequate access to healthcare and the contextual differences in ethnic communities. So, mental health professionals have noted that race and racial stereotypes have influenced research and diagnoses in different ways and negative ways. And because of these biases and barriers to accessing mental health services, we don't have a full or accurate picture of how mental health disorders actually affect different racial groups. And so understanding these patterns is complicated because there are intersecting factors like race, gender, income, and education. So, for example, there was a study done on Black men and women in Detroit, and the study showed that higher income was linked to lower depression and anxiety, while unemployment was linked to higher levels of these issues in working age African American adults. So, these studies emphasize the importance of recognizing and differentiating the experiences of diverse groups in mental health research. Mental health and psychopathology are not fully understood in ways that consider each group's cultural context. For instance, while many explanations of mental health challenges relate to the harsh conditions in many communities, definitions of positive mental health for older ethnic groups often overlook the long-term effects of these conditions. They also overlook resilience factors and the impact of limited access to healthcare. And so a comprehensive approach must be taken to assess ethnic differences. So care must be taken when interpreting data and take into account all aspects of the biopsychosocial model. Assessment is a structured way of measuring, understanding, and predicting a person's behavior. This process collects information about a person's medical, psychological, and social backgrounds through methods like interviews, observations, tests, and clinical evaluations. Often a team of professionals performs this type of assessment, where a doctor might focus on physical health and medications, a psychologist on thinking abilities, personality and social skills, a nurse on daily life skills, and a social worker on finances, social support, and environmental resources. Adults of any age can be given intelligence tests, neuropsychological exams, and mental status exams to assess mental health and cognitive function. Mental health status exams would be the mini mental status exam, which is particularly helpful for quickly screening cognitive abilities. It's important to note that tools such as the MMSE are used for general screenings and not for a final diagnosis. Psychological functioning is usually evaluated through interviews, observations, and tests or questionnaires. A clinician typically starts with an interview and a brief screening tool, then follows up with more detailed personality tests or in-depth interviews if needed. So this is an example of the mini mental status exam. And so this is a brief screener to see if the person has any cognitive issues. Cognitive areas are related to orientation to time. So asking the person, what's the date? Registration. And so the patient will be asked to repeat words over and over again. After hearing a list of words, they will repeat the words up to 5 times. And then see if they are listening and they are able to recall these words. Naming and reading stimulus form are the other two. So the administrator will ask the person what the item is after pointing to an item such as a pencil or pen. And then the reading stimulus form is asking the person to read something and to do what it says. So there are some factors that can influence assessments especially negative biases about people. And these are common and include stereotypes related to race, ethnicity, gender, and age. Clinicians may hold such biases, which sometimes lead them to diagnose problems in adults from specific racial or ethnic backgrounds that may not actually exist. Ageism can also lead to misdiagnoses in older adults, where treatable issues like depression might be overlooked in favor of untreatable ones like dementia. Positive biases can also interfere with accurate assessments. So, for example, assuming that older adults are often just eccentric may prevent a thorough evaluation of their abilities. The best way for clinicians to avoid bias is to be well informed about their clients. Clinical interviews are the most common assessment tool, and they're helpful because they provide both direct answers to questions and nonverbal clues like emotions. Interviews can gather background information and they can help the clinician decide on next steps. They can also build trust with the client, allow the client to provide informed consent, and check treatment effects. And this is important for adults of all ages, but for older adults, shorter sessions and attention to sensory or cognitive issues may be needed. There's a lot of other formal assessments which use self-reported formats. So they will use Likert scales for patients to report how they're feeling. For older adults, their reliability and validity of psychological assessments that include scales could be a concern. And so family and friends could be valuable sources of information, especially if the client can't fully describe the issue. In cases like dementia, differences between the client's report and others can help with a diagnosis. And so it can be very important to get family input, which can be helpful through interviews or self-reports. There's also psychophysiological assessments, which explore the link between physical and mental functioning. And so typically this includes EEGs that measure brain waves, or measuring heart rate, muscle activity, and skin temperature. And these measures can show the body's response to anxiety or fear. There's also neuroimaging, which helps to see if brain structures or changes are linked to specific symptoms. Observations are also useful, especially for specific behaviors like acting out. And observing clients in settings like their home or clinic through video tools can provide valuable insights. Performance-based assessments give clients a task to complete. These tasks, such as remembering a list or solving a puzzle, are often used in cognitive and neuropsychological assessments to measure memory, drawing, or problem-solving abilities. Treatment for mental health disorders usually includes two main approaches: medical treatment and psychotherapy. Medical treatment mainly uses medications to address the physical causes of the disorder, while psychotherapy involves talking with a clinician or joining a group session. It's important to consider age-related differences when using either approach. So as we explained in Chapter 3, medication effects can change with age. So treatments for older adults have to be closely monitored to avoid over or under medicating. And this can worsen problems or cause new ones. So in psychotherapy, clinicians adapt their techniques to meet the specific needs of older adults. And so a key aspect of psychotherapy is ensuring that the methods used are effective. Evidence-based treatment, which relies on proven research and clinical results, has become a standard. Major professional associations provide guidelines. So for example, the American Association of Family Physicians offers tools for evidence-based medical treatments, and the American Psychological Association has set criteria for evidence-based psychotherapy. Evidence-based therapies, proven effective for adults, generally work well across all ages and are preferred. In discussing specific disorders, we will focus on these evidence-based treatment approaches. So now we're going to briefly go over depression disorders in older adulthood and how this manifests and how depression tends to be treated. So overall, many people feel down or sad from time to time. This is normal as a response to either a work issue or relationship challenge, or even grieving the loss of a loved one. But one question that keeps coming up is, how is depression actually diagnosed? And are there age-related differences in symptoms considered during a depression diagnosis? Another question is, how is depression treated once the symptoms come up? There is a common myth among older adults, and the myth is that most older adults are depressed. However, contrary to this belief, the rates of depression actually drop by more than half from young adulthood to old age among healthy individuals. The rates of clinical diagnosis vary across ethnic groups. So for example, it tends to be higher for Latino older adults and lower for older African American adults. Depression also commonly accompanies other chronic health conditions. So if a person has a chronic health condition, they have an increased risk of developing depression. Age-related decline in depression prevalence does not occur in all cultures. So for example, depression symptoms might look very different depending on the culture. Depression symptoms among Chinese adults increase over a 24-year period in one study. For those who do experience depression, we will examine the process of diagnosis and treatment. So this is a graph that shows you the trends depending on sex, age, and race and ethnic groups. Shows you the differences in terms of depression diagnoses. So the average age in the US for a depression diagnosis is in the early 30s. Fewer than 5% of older adults living independently show signs of clinical depression, and this rate jumps up to over 13% among those that need home health care. Older adults are at a higher risk for depression when they have a chronic health condition. So this includes those with chronic illnesses like diabetes, cancer, heart disease, and Parkinson's. They are also at a higher risk for depression if they are in a nursing home residence, and even family caregivers. So family caregivers also tend to be at a greater risk for depression. Rates differ across gender, racial, and ethnic groups, but an accurate diagnosis is often hindered by a person's limited access to care and diagnostic bias. So women in the US experience depression at twice the rate of men, and those identifying with multiple races or ethnicities have the highest rates among all groups. White adults report the highest rates among single race groups, followed by Hispanic and Black adults, while immigrants also face higher depression rates. Depression rates surged during the COVID-19 pandemic, and this highlights the need for culturally sensitive diagnostic and treatment guidelines. These guidelines consider cultural contexts, helping clinicians avoid errors based on misunderstandings of cultural behaviors. So according to the DSM-5 TR, this sets the criteria for diagnosing depression in adults. And to be diagnosed with depression, a person must experience at least 5 symptoms over a 2-week period, with one of them being either a depressed mood or the loss of interest or pleasure in activities. So at least 5 symptoms need to occur, and they include feeling depressed most of the day and nearly every day. There has to be a significant decrease in interest in almost all activities most of the day, nearly every day. Typically, people with characteristics of depression also have weight loss without dieting, weight gain, or changes in appetite. It slowed thought process and reduced physical movement. This can be observed by others and not just subjectively felt. A person also can experience fatigue or loss of energy almost daily, feeling a worthlessness or excessive guilt nearly every day. Typically, people with depression have difficulty concentrating, making decisions, or being indecisive nearly every day. And lastly, frequent thoughts of suicide or death without a plan, a suicide attempt, or a specific plan for suicide. For a diagnosis, these symptoms must cause significant distress or interfere with social, work, or other important areas of life, and should not be due to substance use or another medical condition. So there's also physical symptoms that accompany depression. So general symptoms and characteristics of people with depression often tend to have insomnia, changes in appetite. There's also some research that links depression to diffuse pain and discomfort. People with depression can also experience trouble breathing, having headaches or migraines, experiencing fatigue, and sensory loss. As I mentioned earlier, the general symptoms and characteristics have to last at least 2 weeks in order for a person to qualify for depression, and other causes must be ruled out. So, symptoms of depression should not be caused by substance abuse or other medical issue. A clinician must determine how symptoms are affecting daily life. So, if the symptoms are causing the person significant distress or problems in their daily life and functioning, the clinician makes the decision then to diagnose someone with depression. There are several risk factors for depression in the older adult populations, and these include being female, unmarried or widowed, experiencing stressful life events, and lacking social support. Having a chronic illness can also be a risk factor, as well as living in a nursing home or being a caregiver due to caregiver burden. Also, being a minority can be a risk factor. There are some key differences in how depression is experienced by women and older adults compared to what was previously described. And so, according to one article, there are some ways that depression can differ between men and women. So, for example, women with depression often feel anxious and scared, while men tend to feel more guarded. Women tend to blame themselves more for their depression, whereas men are more likely to blame others. Women usually feel sad, worthless, and indifferent when depressed, while men often feel irritable and angry. Women often self-medicate with depression by turning to food and friends, while men may use alcohol, TV, or sports. Women may feel tired and anxious, whereas men might feel restless and agitated. And women are more open about their feelings of self-doubt and despair, while men tend to often hide those feelings and seeing them as a sign of weakness. And so these are just some of the differences that studies have shown between men and women when depression manifests. So there are assessments that are aimed to diagnose someone with depression. So the Beck Depression Inventory includes questions about feelings and physical symptoms. And while these symptoms can indicate depression in young adults, they may not be related to depression in older adults. So depression may look differently for older adults. And so to address this, the geriatric depression scale is developed specifically for older adults. And this scale omits physical symptoms and uses a simpler response format. And this reduces the age-related bias that's often found in self-reported measures for depression. There are some perspectives on what causes depression. So one is the biological perspective, and this would be depression is caused by some sort of genetics or imbalance in the brain or brain structural changes or even neurotransmitter alterations. And research shows that genetics accounts for about 40 to 50% of depression risks in adults. And family studies reveal higher depression rates in relatives of those that are diagnosed. So, and this is especially the case for early onset cases. Neurobiological studies suggest that severe depression in later life is often due to imbalances in serotonin and norepinephrine. And so low serotonin levels often can result from prolonged stress and that can lead to symptoms like early morning awakening, difficulty concentrating, fatigue, and a loss of interest in activities. The second perspective emphasizes psychosocial factors such as stress, loss, and personal beliefs. So this can be stressful life events such as losing a spouse, a job, or having a health issue. All of these can be associated with depression, and so it's often the interpretation of these losses that leads to depression, not the stressful life event itself. The internal belief systems play a crucial role. So, for instance, believing that a spouse's death occurred because you are a bad person can lead to depression. And this view highlights how individuals appraise stressful life events, considering their own attributions, self-efficacy, and control beliefs. And so those with depression often feel responsible for these negative life events and believe that things won't improve, and they view their lives as chaotic. And so therapies that are based on these theories aim to change these negative internal beliefs. Treatment for depression typically involves a combination of medication and psychotherapy. And most of the medications for depression work by adjusting the balance of specific neurotransmitters in the brain. And so some of these would be selective serotonin reuptake inhibitors, which are SSRIs. So these would be Prozac, Zoloft. Norepinephrine reuptake inhibitors are SNRIs. This would be Cymbalta and Effexor, some of the common ones. And norepinephrine dopamine reuptake inhibitors are known as NDRIs, and these are Wellbutrin and Remeron. And these generally have the fewest side effects. There's also older treatments out there that could be used if the preferred medications are ineffective. So, for example, tetracyclic antidepressants are a form of treatment, but they can have serious, sometimes fatal side effects. In some cases, standard medications may not work, or a fast-acting solution is needed, since most antidepressants take weeks to become effective. And in addition to medication and brain stimulation, there's psychotherapy, and that's a common treatment for depression. Two effective forms of therapy for adults are behavior therapy and cognitive therapy. Behavioral therapy focuses on increasing rewards and positive experiences that people with depression receive from their environment. And this is achieved through practice and homework assignments, such as engaging in more social activities or joining clubs. Cognitive therapy, on the other hand, centers around changing negative thoughts and beliefs about oneself, the world, and the future, and these can contribute to depression. And so cognitive therapy often focuses on reframing those negative thoughts and feelings. Individuals learn to recognize and reevaluate negative thoughts to develop a more positive outlook of the world and themselves. And cognitive behavioral therapy is effective for older adults. So this is very encouraging because older adults may not respond as well to medications due to age-related changes in metabolism. Anxiety disorders are a group of 6 conditions characterized by intense feelings of unease, panic, or terror. So some of these include generalized anxiety disorder, panic disorder, phobias, agoraphobia, as social anxiety disorder, and separation anxiety disorder. And in the United States, about 30% of adults report symptoms of anxiety disorders in any given year. Overall, women are 60% more likely than men to experience an anxiety disorder at some point in their lives. And a significant concern regarding anxiety disorders in older adults is that anxiety can sometimes be a valid reaction to specific situations. So, for example, helplessness anxiety arises from a real or perceived loss of control, which tends to decrease with age. Additionally, experiencing a series of negative life events can lead to heightened anxiety. Many older adults exhibiting symptoms of anxiety may have underlying health issues that contribute to their anxiety. So it's essential to first assess whether the anxious behavior is an appropriate response that doesn't require medical intervention. And it's important to separate these secondary causes of anxiety from the symptoms themselves so that each can be addressed appropriately. So we are trying to differentiate between normal worried responses and pathological anxiety in a client. And according to Zarit, the key characteristics of anxiety disorders in later life tend to include distress, frequent and uncontrollable worry, muscle tension, and sleep disturbances. Anxiety disorders can be treated effectively with a combination of medication and psychotherapy. So some medications include benzodiazepine, beta blockers, and paroxetine, which is an SSRI. While these medications can be moderately effective, they must be closely monitored in older adults due to the low dosages required and the higher risk of side effects. For older adults, psychotherapy is often the preferred treatment, particularly cognitive behavioral therapy or relaxation therapy. Relaxation therapy is particularly effective, easy to learn, and can be applied in various situations. And these psychotherapeutic methods typically require only a few sessions, and they do have high success rates and provide clients with techniques they can use independently. So now we'll briefly discuss post-traumatic stress disorder, also known as PTSD. PTSD is a mental health condition that's triggered by experiencing or witnessing an extremely stressful or frightening event. Symptoms can include flashbacks, nightmares, intense anxiety, and persistent intrusive thoughts about the event. While most people struggle to cope with and adjust after a traumatic experience, they often recover over time with self-care. However, if symptoms persist, worsen, or last for months or even years and interfere with daily life, then PTSD may be present. Diagnosing PTSD requires a thorough and careful process to rule out other possible reasons for an individual's distress. Beyond assessing if symptoms meet the clinical criteria, clinicians must also check if the person consistently or repeatedly experiences any of the following dissociative symptoms. So two common dissociative symptoms are depersonalization and derealization. Depersonalization is ongoing or repeated feelings of detachment from one's thoughts or body, as if observing a person from the outside. And so a person might feel like they are in a dream, or they're feeling a sense of unreality about themselves, one's body, or time. Derealization is persistent and reoccurring feelings of feeling that your surroundings and your environment are not real. They are dreamlike, distant, or distorted. And these dissociative symptoms should not be due to substance use or another medical condition. People with PTSD or who have experienced trauma often face additional mental health issues like panic disorder, depression, substance use, or suicidal thoughts. Treating these conditions can aid in recovery from trauma, and support from family and friends is often crucial. Common therapy methods for PTSD are similar to those used for depression, anxiety, and substance use. Two popular forms of cognitive behavioral therapy for PTSD are exposure therapy and cognitive restructuring. Exposure therapy involves gradually and safely confronting the trauma-related memory or locations to manage fear. Cognitive restructuring helps people process the traumatic event realistically, especially if they remember it differently or feel guilt that isn't warranted. Medications for PTSD are also often those used to treat depression and anxiety. Substance use disorder is a treatable mental health condition that impacts a person's brain and behavior, and it results in difficulty controlling the use of substances such as legal or illegal drugs, alcohol, or medications. And so we find that the elderly person's drug of choice tends to be alcohol. And so alcohol is a commonly abused drug across age groups, which makes it useful for comparison. Alcohol use disorder is defined as a pattern of drinking that leads to significant and recurring consequences. And it shows a person's lack of control over alcohol use. It is diagnosed when an individual meets at least 2 of the 11 criteria within a 12-month period. And so, for example, in your table, table 10.3 of your textbook, it shows the different symptoms that are usually a sign of alcohol use disorder. There are gender and ethnic differences in alcohol dependence. So it tends to be 2 to 6 times higher for men than women. Widowers over the age of 75 tend to have the highest rate of alcohol use disorder, and Native American rates are higher than European Americans. And so rates of alcohol abuse vary among racial and ethnic groups. Alcohol consumption increased during the COVID-19 pandemic by about 14% overall, with a 41% increase in heavy drinking reported by women. Alcohol-related deaths rose approximately 25% between 2019 and 2020, which was the pandemic's first year. Alcohol use disorder shows 2 main patterns of onset with age. Early onset typically begins in young adulthood or middle age and often happens with binge drinking. And then late onset usually follows a pattern of drinking above recommended limits, so having more than 2 drinks per day for men and 1 for women. Early onset is usually more severe and accounts for about 2/3 of older adults with alcohol use disorder. And this group is predominantly male. They have more antisocial traits and they face more alcohol-related health issues. In those that have the later onset alcohol use disorder, they are often more affluent and they include more women, generally having fewer health problems due to shorter heavy drinking histories. And this group's increased drinking often follows stressful life events such as retirement, a loss of a partner, or a health issue that's causing a lot of pain. So when we look at alcohol use disorder across the lifespan, we see important differences in drinking habits and outcomes depending on age groups. So emerging adults tend to binge drink, and they often tend to binge drink around age 21. So this is like the peak age where this can lead to issues such as alcohol poisoning, DUIs, and assault. Starting to drink early, especially during teen years, increases the chances of developing alcohol dependence and potential brain damage. Young adults also tend to feel fewer effects from alcohol, such as sleepiness or loss of coordination. So it may actually lead them to drink more. And even though they're not feeling the effects as much, their cognitive skills are more impacted, making them worse at complex tasks like driving. And so this is also why DUIs are more common in this age group. In middle age, the health effects of long-term heavy drinking take place. So people often tend to have liver and pancreas disease. They're adding an increased risk for cancer and heart problems. So these start to show up, leading many to seek treatment. And then for older adults, even small amounts of alcohol can be risky because older adults have a slower metabolism, so the alcohol is staying longer in their body. They also tend to be on medication, so if they do drink, there can be interactions between alcohol and medications, which can also increase risks for health issues. Older adults may develop alcohol problems simply by continuing their past drinking habits, even if they drank only moderate amounts when they were younger. Diagnosing alcohol dependence in older women can be especially tricky because they're more likely to live alone. Treatment for alcohol use disorder aims to reduce alcohol use, address other health issues, and build social support. 3 main treatment options include mutual support groups. So Alcoholics Anonymous is a support group that provides peer support to help people stop alcohol or drug abuse. Behavioral treatments are counseling, so this could be done individually or in groups to help reduce or quit drinking. Medications are disulfiram, which creates unpleasant symptoms if alcohol is consumed, and that helps people avoid drinking. Naltrexone lowers pleasure from drinking and reduces cravings by blocking brain receptors. And lastly, acamprosate eases withdrawal symptoms by balancing brain chemicals. So all of these treatment methods, they're often combined and they can help many people reduce or stop drinking altogether. Delirium involves sudden confusion and decreased awareness of surroundings, often with issues in attention, memory, and speech. It may also impact a person's perception, sleep patterns, personality, and mood, and these symptoms generally worsen for older adults. And so it's a disturbance of consciousness that develops rapidly, and the rapid onset can fluctuate throughout the day, and it may go unnoticed in older adults due to stereotypes about aging and cognitive decline. Clinicians recommend using assessments like the confusion assessment method to screen older adults systematically. Delirium can result from various causes, which include medical conditions, dehydration, medication effects, substance misuse, toxins, or sleep deprivation. Older adults are especially vulnerable due to the likelihood of medication interactions. Treatment focuses on addressing the underlying cause. When correctly identified, it is often successful. Diagnosing delirium requires differentiating it from depression and dementia and pinpointing its cause. Approximately 1/3 of cases, such as those from dehydration or medication, are preventable. While many cases of delirium are treatable, it can sometimes lead to permanent brain damage or be fatal. Dementia is not a single disease, but it's a group of disorders that are marked by cognitive and behavioral impairments that result from permanent brain damage. The most recognized type of dementia is Alzheimer's disease, but there are several other significant forms, including vascular dementia, Parkinson's disease, Huntington's disease, alcohol-related dementia, Lewy body dementia, and AIDS dementia complex. Alzheimer's disease is the most prevalent form of progressive, degenerative, and ultimately fatal dementia, and it represents about 60 to 80% of all dementia cases. Due to women generally living longer than men, the lifetime risk of developing Alzheimer's disease at age 45 is approximately 1 in 5 for women and 1 in 10 for men, and both risks increase slightly at age 65. The likelihood of Alzheimer's disease also rises with age, increasing from 5.3% among individuals ages 65 to 74 to about 35% among those ages 85 and older. As the older adult population grows significantly in the coming decades, the number of Alzheimer's disease cases is projected to roughly triple. The main symptoms of Alzheimer's disease involve gradual changes in cognitive abilities and related functions across 10 areas. Memory loss that disrupts daily life, difficulty managing everyday tasks, challenges in completing familiar activities, confusion regarding time or place, trouble understanding visual information, new issues with language, misplacing items and struggling to retrace steps, poor judgment, withdrawal from work or social engagements, and changes in mood and personality. The brain changes associated with Alzheimer's disease are microscopic and progressive, and they ultimately lead to significant brain damage and death. And these key changes include rapid cell death, neurofibrillary tangles, and plaques that consist of a core of beta amyloid, which is a protein that's surrounded by degenerated fragments of dying or dead neurons. There are also alterations in neurotransmitter levels and inflammation in brain structures. Rapid cell death primarily occurs in the hippocampus, the cortex, and the basal forebrain. The cell death happens much more quickly than in normal aging, and it results in significant brain shrinkage. Each neuron contains tubules made of tau proteins that function like railroad tracks to transport nutrients and information from dendrites to synapses. When excessive phosphate attaches to these tau proteins, it causes these tubules to form neurofibrillary tangles, which are clusters of twisted neurofilaments. These tangles disrupt the transmission of nutrients and information and ultimately lead to neuron death. Neurofibrillary tangles are found in various brain areas, and their quantity is directly related to the severity of symptoms, particularly memory impairment. So the major characteristic of dementia is the gradual change in cognitive decline. So it doesn't happen overnight. It's rather a gradual process that gets worse and worse over time. And dementia causes people to lose their sense of identity because as they're struggling to remember personal details, they start to fail to recognize friends, close family members, and important figures. More than 50 million people globally suffer from dementia, and that limits their ability to live independently. So this number, according to the World Health Organization, is expected to triple by 2050. In the US alone, dementia costs exceed $320 billion annually, and over 10 million caregivers provide unpaid support valued at over $280 billion. The average lifetime care cost for someone with dementia is around $380,000. And the COVID-19 pandemic worsened the situation as family visits were restricted and in-home support became hard to access. People with dementia in care facilities were at higher risk of infection, and the stress on families and caregivers was often overwhelming because of that. The early symptoms of dementia are often subtle and they can resemble other issues like depression or stress. So, for example, someone in a demanding job might start missing deadlines or managing time poorly. And over time, these symptoms worsen. And so, a person who once handled complex tasks like managing finances may now struggle with simple math. Others may have trouble doing everyday activities such as setting the table. Personality changes are also common, and so someone with who was outgoing before might become socially withdrawn, or a kind person might become aggressive. Emotional challenges such as depression, paranoia, and agitation can also emerge, and so people with dementia sometimes make unfounded accusations like accusing loved ones of infidelity or theft without any basis. Wandering is also common and can be dangerous since the person may not know where they are or how to get back home. And research shows that this behavior is likely due to damage in part of the brain responsible for navigation, which often occurs early in Alzheimer's disease. Symptoms often worsen in the evening, which is known as sundowning, and in the advanced stages, dementia can lead to incontinence and a complete loss of mobility, making the person fully dependent on caregivers. The course of Alzheimer's disease is called the Alzheimer's disease continuum, and it has three main stages: preclinical Alzheimer's, mild cognitive impairment due to Alzheimer's, and Alzheimer's dementia. The dementia stage is further divided into mild, moderate, and severe phases. Not everyone in the early stages will progress to Alzheimer's dementia. In the preclinical Alzheimer's disease phase, this is the earliest stage where people show measurable brain changes, like the buildup of beta amyloids and tau proteins, and the reduced glucose metabolism, but they have no memory loss or other symptoms yet. In the mild cognitive impairment phase, individuals have brain changes linked to Alzheimer's and they show new but subtle cognitive issues. So they'll have memory or language problems initially, and these problems may be noticeable to them. They can also be noticeable to close family, but they don't yet interfere with daily activities. In mild Alzheimer's disease, This is the stage where people can still manage most of their daily lives on their own, but they start to need assistance with tasks. So these would include complex ones like managing finances. They may need more time to complete tasks, but they can still drive, work, and enjoy hobbies. In the moderate Alzheimer's disease phase, this is typically the longest stage where memory and language problems become more pronounced, confusion increases, and it becomes difficult to do multi-step tasks like bathing or dressing. Incontinence may occur, and there might be personality changes, including suspicion or agitation. People may also start to forget close family and friends. And in the severe Alzheimer's disease stage, people lose the ability to communicate verbally and require constant care. So this is where the damage to the brain areas are now affecting movement. They're affecting people's ability to swallow food or drink. And so this increases the complications like blood clots, infections, and sepsis. So as I mentioned earlier, there are key biomarkers that are associated with the risk of Alzheimer's, and these include beta amyloid, tau proteins, and neuroinflammation. There's also genetic research that highlights the role of apolipoprotein 4 linked to chromosome 19, which may signify or significantly contribute to the formation of plaques. And so individuals with this genetic variant are at a higher risk for developing Alzheimer's disease compared to those with the more common apolipoprotein 3 variant. There is also some evidence suggesting that COVID-19 may increase the risk of developing Alzheimer's in people with this mutation. There is also another gene known as the ABCA7 gene, and that's been linked to increased chances for Alzheimer's disease in African Americans. There's also the beta amyloid cascade hypothesis, and so this is a hypothesis that researchers refer to as a key process in the development of Alzheimer's. And this hypothesis suggests that deposits of beta amyloid lead to the formation of neuritic plaques, which then cause neurofibrillary tangles and ultimately result in neuron death. And when they're severe enough, it can lead to Alzheimer's disease. While this theory has been popular since the early 1990s, there is a lack of strong evidence showing that beta amyloid is the main cause. And additionally, no medication aimed at reducing beta amyloid deposits has shown clear success in treating the disease. However, there's one mystery that remains, and the question is, why does beta amyloid deposits form in the first place? And some research suggests that these deposits may be the brain's natural response to infection, even from mild cases that don't cause noticeable symptoms. And this theory posits that beta amyloid acts as a natural antibiotic to protect the brain from infection. Studies indicate that these deposits may trap bacteria, reflecting an immune response. And so researchers are investigating whether this response is triggered by real infection or a false alarm. And there's other studies that are looking into how changes in the brain's blood flow could contribute to Alzheimer's. So for example, there was a paper done in 2012 that found that increased blood flow in the frontal cortex and decreased blood flow in the parietal and temporal lobes led to significant cognitive impairment. And what's interesting is that these blood flow changes were detected before noticeable cognitive decline. And additional research found that people with vascular risk factors, such as high blood pressure, are more likely to progress from mild cognitive impairment to dementia. Some researchers are also exploring the idea that Alzheimer's disease may partly result from the brain's inability to use glucose and produce energy effectively. So for example, studies have shown that processed foods that are high in fat and nitrites can worsen cognitive decline. High blood sugar levels are also linked to an increased risk of Alzheimer's, even in people without diabetes. Currently, there are no effective medical treatments for Alzheimer's disease in the middle and late stages, and there's no way to prevent it. The focus is mainly on easing symptoms rather than stopping the disease. Most research looks at medications to improve cognitive function, particularly memory, in the early stages. In 2022, a study on the drug Lecanemab showed some improvement for those with mild impairment. However, the medications approved by the Food and Drug Administration so far offer little relief as the disease progresses, and a few promising options are in development for later stages. The best strategies for managing Alzheimer's is behavioral approaches. They tend to be more effective than drugs, and they can be used from the time of diagnosis throughout the course of the illness. Behavioral strategies can be simple, like using large calendars to help with time orientation, or more complex, like memory techniques based on the EIEIO method. One effective behavioral strategy is called spaced retrieval. This method helps people with Alzheimer's remember new information by gradually increasing the time between attempts to recall it. This technique is simple and can be used to help residents remember staff names and other information, making it useful in home and care settings. It's easy for caregivers to learn, and research shows that combining spaced retrieval with other memory aids can be even more effective. Additionally, spaced retrieval can be used for teaching other skills, such as helping those with swallowing difficulties relearn how to swallow, or supporting them during meals. So there are other forms of dementia other than Alzheimer's. As I said before, dementia is a group of diseases that cause the brain and cognitive functions to gradually decline. So one is vascular dementia, which is a common type of dementia that occurs due to restricted blood flow to the brain. And it's often caused by numerous small cerebral vascular accidents. It can also be caused by conditions like atherosclerosis, which can lead to heart attacks or strokes. And a stroke happens when blood flow is disrupted, usually due to a blockage. A large stroke can cause sudden, severe cognitive decline and affect specific abilities, rather than causing a gradual decline seen in other dementias. Symptoms vary widely based on which areas of the brain are affected. So people with vascular dementia often have a history of heart or blood vessel issues, and common symptoms include having high blood pressure. The progression of vascular dementia can be faster than Alzheimer's disease, with an average lifespan of 2 to 3 years after onset, but in some cases it may progress slowly. Lewy body dementia is the third most common type of dementia and is diagnosed in a lot of people as well. So it's characterized by the presence of Lewy bodies, which are abnormal clumps of protein that develop in brain cells. And these clumps of protein can lead to a loss of dopamine and acetylcholine. This loss causes cognitive decline, and diagnosing it can be challenging because its symptoms overlap with other forms of dementia. Key symptoms include visual hallucinations, disorganized thinking, severe cognitive decline that affects daily life, balance problems, sleep disturbances, and agitation. Lewy body dementia typically develops cognitive symptoms within a year of movement issues, while in Parkinson's disease, cognitive symptoms arise more than a year after movement symptoms start. Parkinson's disease is primarily known for movement symptoms. So with that, you get slow walking, difficulty getting into or out of chairs, and having slow hand tremors. And these symptoms result from the loss of neurons in the midbrain that produce dopamine. Early symptoms would be the slow movement, muscle stiffness, and tremors. You also start to see smaller handwriting in people with Parkinson's. They can lose their sense of smell. They can also have sleep problems and changes in their voice. And as the disease progresses, we start to notice cognitive symptoms and changes in mood and behavior.